Good afternoon, everyone. We'll just wait a couple more minutes. We are still awaiting a couple of speakers, and we'll get started. I promise you a good session, but we'll just wait another minute or two. I appreciate your patience.
It's not activated yet.
I just bought this here. She's the wife of your organizer. What's his name? Angry Sani. And so she made me buy all these jewelry. It's incredible. I love it. All right. Good afternoon, everyone. Again, thank you for being here. I am Dr. Anu Vadva. I'm a professor of anesthesiology in Dallas, Texas, and the immediate past president of the International Society of Perioperative Care of Obese Patients. So I'm really very, very proud to be here and thank the organizers extremely for inviting us here. This is my third IFSO in a row, and it has been wonderful collaboration throughout the years. We are the society that mostly collaborates with the ASMBS and with IFSO. And you'll see some of the results from our collaboration today. So we have 4 speakers. We have a slight change in the order of our speakers. Instead of Dr. Farooq Badiuddin, we'll have Dr. Yan Moulier, who is an extremely engaging speaker. I can vouch for that. I've been hearing him for more than a decade, and he's just absolutely an incredible anesthesiologist. He's the chairman of Anesthesia at Bruges, Belgium. In addition to his degree in medicine, he's also a PhD from University of Pennsylvania, UPenn, which is the topmost institution in the US. He's the founder of the European Society, of the sister society of Ispcop is the European Society of Perioperative Care of Obese Patients. So if any of you are anesthesiologists who do bariatric procedures, please join his society in Europe. He has done incredible amount of work on opioid-free anesthesia. And you can see many of his videos on YouTube describing opioid-free anesthesia. His recent interests have been lung protective ventilation and prevention of peritoneal inflammation after bariatric and robotic surgeries. So I am sure you'll find his talk today extremely engaging. I invite Dr. Yan Moulier on what can we still do to improve from the new Erabs guidelines based on a large survey that we did in collaboration with IFSO. Thank you.
Thank you very much for the nice words and the long introduction. The lecture is quite short, so we will have to hurry a little bit to get through. What we will do is we will go to the guidelines that are really important, the basic, and look what the answers were from the survey we did with the Ispcop together, and also look up what can be moved in the past, or in the future from the past, and what can we improve. I'm looking if we can go forward, or next slide. Okay. Okay, so we have here already the first table of the new Erabs guidelines, and we have no time to go in everything in detail, but I would focus on 2 aspects the weight reduction, and the weight reduction was said be important for afterwards having the patients following the scheme. Although there is one important thing missing we will focus on, and that is the advantage for the surgeon to have more workspace. And the second aspect is all about the exercise preoperative, the prehabilitation, because there also is new information on that item. If we look to the survey, what we found out was that the preparation is not done that much, as you can see. Follow up on the survey. Most are really not doing anything at all. But if you look to the surgeons, they were answering that they were doing a lot of preparation regarding exercise. Now, the incentive spirometry, all the publications are not showing any effect, so practically this you might even able to forget. What is important is more the postoperative CPAP and the early prophylaxis against thrombosis. Preoperative CPAP also didn't come out as being quite important. You should mention in this study all patients get opioids intraoperative. There is no verification of full reversal, and the extubation is not always done regarding the long protective ventilation guidelines. The volume of the liver is decreasing dramatically if you put a patient on a 2 or 3 weeks protein diet. And as you can see by the red bar, in 2 weeks we get 5% total body weight reduction, 10% of intra-abdominal fat, and more than 20% of liver fat. This means there is a lot more space in the abdomen. You are able to work at a lower pressure, and the surgeon will be able to work at a lower intra-abdominal pressure, giving less peritoneal damage. This is, for me, the most important aspect in the preoperative preparation of a patient, and it is not mentioned yet in full in the new Erabs guidelines. Prehabilitation, well, until now it seems not to be that important, but new papers coming out showing indeed the impact also on the postoperative cognitive dysfunction, and certainly the patients with metabolic syndrome and older patients are at high risk. Prehabilitation means that really we go not just for incentive spirometry, but for strong exercise, increasing the physical reserve and function, and on top with the other ERAS guidelines, the outcome should be improving. There's a lot that can be done here to avoid these all neurocognitive disorders postoperative. In fact, also our anesthesia approach we should looking up, and as you can see here, the patients with metabolic syndrome are at an increased risk. The drugs like the opioids, benzodiazepines, neostigmine should also be avoided. Anesthetics to choice, dexmedetomidine, lidocaine intravenous, ketamine, these are the drugs we use for opioid-free anesthesia. So it doesn't seem to be avoiding the opioids, but the use of the lidocaine dexmedetomidine that is quite protective. Minimal invasive for the surgeon and avoiding hypotension, fluid mismanagement. Insufficient sympathetic block is also a risk factor. If we look here to the in this table 1, so we should say the preoperative weight loss is very important to give laparoscopic workspace. I had no time to show these slides on the improvement. Certainly for the males with central obesity, prehabilitation helps only if it's intensive, and it might reduce the brain dysfunction. Table 2, if you look to the dexamethasone, 8 milligrams that is suggesting, it's actually suggested for avoiding nausea and vomiting, but it's much more important to avoid and reduce the inflammatory reaction, as indeed is stated, but not in detail. Just one slide here. On top, no laparoscopy, healthy peritoneum, 1 hour and 2 hour laparoscopy at a pressure of 15, dramatic destruction of the peritoneum. And it means that we really, and if you look here in the answers, most of the anesthesiologists are giving a higher dose of dexamethasone, more than 5 milligrams, 8 up to 10. The intraperitoneal lidocaine is working also very effective, but not available yet. That's why almost no one is doing this yet. But very important and good is the lowest intra-abdominal pressure possible. Once you reach 3 liters in the abdominal volume at the start, keep it at this pressure and don't go for higher volumes and higher pressures. The clinical deep neuromuscular block is something else that might be helping. As you can see, only 50% of us are doing that, so this should be more. These are the studies showing that the dexamethasone, as you can see, is reducing dramatically the peritoneal inflammation, thus this should be a standard approach in every laparoscopic case. And as you can see here, the lower the intraabdominal pressure is and the shorter the pneumoperitoneum, you will see the less CO2 absorption or the less inflammatory reaction. And here also in the green bars, by using lidocaine dexamethasone from the opioid-free, we got a lot less CO2 absorption, less inflammation. So that's what we said already here regarding this adaptation. The next part, intraoperative, well, we said opioid sparing is the recommendation, BIS monitoring, and also long protective ventilation. It stayed here, very short, but does everyone doesn't understand what it means and what it happens. The opioid sparing, if you can really do that well, you can even go to opioid-free anesthesia. The importance is of less tolerance, less hyperalgesia, certainly in patients with OSAS, the morbid obese patients, or the patient with COPD. Many other side effects of the opioids we can avoid. We have no time to go on in detail on that. But if we ask the questionnaire, we see that already 25% of the anesthesiologists doing bariatric anesthesia are already going for opioid-free anesthesia. That is fantastic, really such a high number. It could be also reflecting the will to go there, as I think not everyone is really on that way. I think most are doing opioid sparing, but still a lot of centers all over the world, and I see a lot of them also sitting here, are doing totally opioid-free anesthesia in an approach to reduce also the peritoneal inflammation. What drugs have been used to get there? As you can see, most of the time it's a combination of alpha-2 agonists, lidocaine, ketamine is the good approach. Otherwise, with one drug you can do that, but you will get too much side effects either. This is an older publication where we have been comparing 9,000 patients, from which 3,000 got opioid-free anesthesia with significant improvement of less complications, less requirement of high dependency. So really, it is an advantage to go there. Intraoperative stress is something that we really have to evaluate, and most of us are still doing that by the classical clinical tools, although new monitoring equipment is becoming available, like the anidinol, on the EMG on the BIS and so on, and helps us to reduce the opioids or even go totally opioid-free in the correct way. BIS is also still limited in use. It should be more. It's now around 40%. It's not just only important to avoid awareness, but also to going too deep has some impact on the risk of postoperative cognitive dysfunction. Long protective ventilation is something very important in the bariatric patient, and we all focus on the beginning of the induction or look to the maintenance, where we will do recruitment and hire PEEP on the moment we see that the compliance is dropping. But the most important moment is forgot by most of us. It's just right before the extubation. And in that I would go to point number 7, avoid endotracheal tube suctioning immediate prior to tracheal extubation, reverse and have a train of 4 of more than 90%, try to have the lowest dose of opioids or no opioids, the sedatives, and very important, extubate with a low inspiratory oxygen fraction. We all have learned to use 80% or even 100% at the moment of the extubation, just to have some more spare time in case you got in troubles. But this means atelectasis in the recovery room. And so by staying on maximum 40% in most of the patients, you will have open lungs on the moment of extubation, and you have to extubate in the B chair, as you can see, with a full reversal and under CPAP. Never let the patient breathe spontaneously through an endotracheal tube. You will also get immediately atelectasis. If you do that, the most important fact, then you can go to maintenance, where you will, according to the lung compliance, adapt your PEEP level and do recruitment when needed. But that's all secondary to the fact of the extubation phase. And then by that, the need for oxygen in the recovery is a lot less. If you really need to give 100% oxygen on the extubation, you have to give a CPAP system with room air for at least 1 or 2 hours to prevent the absorption atelectasis. If we look here to the survey, what we see here, the 100% oxygen at the moment of the induction is also something you should avoid. There you should also stay at the 80%. It's not that dramatic because you still can do recruiting and have using higher PEEP. It's good that the patients are in the B chair during the induction. That is a very important point, and it's great to see that we get there almost 80%. The intubation with a patient fully relaxed is not done that much, and also the recruitment when the lung compliance is decreasing, you can see around 50%. These are things that should improve. In the emerge, you can see that we avoid long-acting sedatives. A final lung recruit before extubation, it's fantastic. We get there already at 65%. And keeping the patient on pressure support and then CPAP at the moment of extubation is very, very good. The 40% oxygen extubation, as you can see, is still not coming through, and avoiding the opioids postoperative well, but that's still something we have to work on. What's your postoperative therapy? We have been looking on the CPAP. Actually, recommendations are to give CPAP to the patient who have a home CPAP. However, if the patient is fully reversed without any opioids, it's only when the patient wants to take a sleep that you have to give his CPAP. Otherwise, you have to give it immediately right after the extubation. Early mobilization is a very important point. We see that even activating the patient to move the legs as long as they are in bed is something that is very important. But actually, all these points should be improved in most of the patients. Monitoring, we should really go for monitoring everything in that. We have no time on that, but the B chair position is something that is very important. And I was astonished to see in the survey that this is already done quite well. During the pre-oxygenation, the induction, during laparoscopy, the surgeon will have a half a liter more workspace. During the extubation, in the recovery and afterwards. So actually, this is fantastic, and it's because that B chair we have been choosing that logo in the past for the European Society, just showing that with the B chair you gain 1 minute safe apnea time, you have a lower or higher compliance and lower pressures to ventilate the patient, and the surgeon is gaining up to half a liter workspace or can work at a lower intra-abdominal pressure if the patient is in the B chair. And so the patient should never be laying flat at the induction, in the waiting room, during the intubation, during the laparoscopy itself, and postoperative. Also, even sitting up would be very good. What should we discuss further for anesthesia? Well, the opioid-free anesthesia, the lung protective guidelines, the B chair, and the monitoring. For surgery, well, I don't know if there are many surgeons in the room. Can you raise your hand if there are surgeons? Yes, indeed. There are still a lot of aspects for surgery that should be added in the ERAS guidelines, and I have no time to cover everything on that. For that, I would say the neuromuscular block, the stapling method, and some other aspects. Neuromuscular block management, you see, is not ideal. Most wait till the surgeon are saying, I have not enough space. That should be automatically. And as you know, we are measuring peripheral on the thumb, so that's why we actually need to go very deep to have just a relaxation on the central muscles. And most of the time, I give it in a continuous infusion because there's always 50-minute difference in spontaneous reversal time between central and peripheral compartment. Fluid and blood pressure monitoring, well, very important is have the blood pressure raising at the end to avoid the problem of bleedings. And so as you can see in this patient, we keep the blood pressure quite low, the whole procedure, but sufficient. But you raise above normal values here, 136 or 140, 150. And by that, the reduction of postoperative bleeding is dramatically. But the intraluminal bleeding is something you have to focus still on that, and for that you have to do an aspiration test or use ask the gastroenterologist to do a gastroscopy to find out if there are bleedings intraluminal to take care of that. Leak test is also something very important, and like I said, this should be done more interoperative, as you see here in the survey. We are reaching roughly 70% for the gastric bypass, but it should be almost 100% to be really, really safe. For the surgeon, have listed here a lot of other aspects that should be taken care of, about the correct stapling. It's not up to me, but I would say to Dr. Dillemans, who is my bariatric surgeon, who really will focus on all these different aspects in doing sleeves or gastric bypass or even revisions, having the staplers, waiting to have full good compression, having the patient dry, and having no torsion and whatever to get that really in line. In the post-operative care, and I'm almost at the end here, oxygen, and we've been talking about that already. The beach and the mobilization, we have been talking about that, is very, very important. And avoiding the oxygen post-operative, if not needed, to avoid the absorption atelectasis. Okay, with that, and I think I'm just in my time of the 15 minutes, I would say we can improve the quality of care by applying the enhanced recovery after bariatric surgery, but we have to combine that with the surgical quality aspects, long protective ventilation, opioid-free anesthesia, pneumoperitoneum protection, and monitoring of anesthesia as much as possible. If you are interested, in December we have a meeting from the Ispcop together with the surgeons, with the best meeting, where we will have some live procedures recorded, discussed over 2 days, and afterwards those who are interested can also follow some bariatric cases opioid free in the operating theater to learn about the approach we are taking here. Thank you.
Hi, Joe Green from United States. This presentation is music to my ears. I've tried to engage some of my anesthesia colleagues for a long time in some of these forward-thinking measures, and I'm often met with the saying, well, you do the surgery, we'll do the anesthesia, don't tell us how to practice, and we won't tell you how to practice. What's your strategy for engaging a more closed-minded colleague?
Well, I had no time, but I always would say, remind of the words of John F. Kennedy. What did he say? Don't ask what the country can do for you, but ask what you can do for your country. So this, in the relationship with anesthesia surgeons, also to the surgeon who would say, think what your anesthesiologist needs to improve his care. And then we as anesthesiologists would think about what you need to improve your care. And don't go in fight, but look to solutions together. And that's why it's with the neuromuscular block, it's with the leak test, with the blood pressure regulation and so on. But understand that it's sometimes difficult to get the blood pressure up, and so you might have to wait a few minutes before being there.
Any more questions from the audience? Okay.
I have one.
Yes,
yes,
please.
a very quick one. Hi, Jan. Wonderful presentation. Thank you very much. Maybe we just discussed about this. I do not totally agree with you when you are talking about preoperative weight loss. I mean that in some cases it's fundamental. In other cases it's completely useless. And it's time consuming. People is coming after plenty of diet, failed diet and so on. So I think that it should be better to try to tailor the situation. Some people, extra BMI or male or diabetics, need a weight loss. Other very young female with a 42 BMI, probably they do not need it. But I don't know exactly how to express it, but I think that it shouldn't be done on every patient.
Well, you're right in that regard. In the past, I was taking out the patients, the males with central obesity, with all the fat sitting on the inside, with a measurement of the waist-height ratio of more than 0.7. You can measure the circumference. You can also measure if there's a lot of fat in your fingers. That means this is all on the outside, that doesn't count. But if, like me, you have no fat on the inside and the bellow is like a round circle, you are not able to do laparoscopy. You need extremely high pressures. And that's the patient we refuse to operate. It's so crucial. I agree that the woman who has, and that's one of the essential questions for every woman, how many children do you have? If it's more than 3 children, we have been proven that the abdominal compliance is a lot larger and the need for weight reduction is less, and because you will easily insufflate. But as we really want to go to very low insufflation pressures, around 8 millimeters of mercury today, with no peritoneal damage at all, then you really need to take every effort in a weight reduction, even in the woman. Then you need to take every effort in to go for a clinical, very deep neuromuscular block continuously. But then you as a surgeon should put your insufflator on a lower insufflation pressure. And if you reach the 8, you can operate as long as you want, there will be no damage at all.
Thank you.
What do you think about brain monitoring during anesthesia? Because we know that from the literature that the use of brain monitoring during anesthesia, like BIS or processed EEG, is the key to avoid the neurological disorder in the postoperative period.
Well, it's not the golden approach to avoid it. Because it's very difficult. The neurocognitive dysfunction it's a large group of problems, and doing a BIS or whatever neuromonitoring will not prevent it in the first place. But at least it's a small step towards that approach. But also I'm mentioning it because there's a huge difference between the depth of anesthesia, the depth of hypnotics, and the depth of stress suppression. And that's where I would say it's not because your BIS is low that the patient doesn't have any stress. And it's not because the stress is low that the patient is asleep. These are two totally different aspects. So you should be monitoring BIS or of another monitor for depth of hypnosis and keep that not very deep, because there are indications that it would be better. And at the same time, you should keep the stress low. And if you measure the stress directly, you will see that sometimes if you use opioids, so we have been overdosing too much. But saying I'm go for opioid sparing, reducing the opioids without giving anything else and having even more stress, that's a disaster too. And the same aspect with opioid free, we have been reducing the dexmedetomidine and the lidocaine dose, because in the past we might have been giving also too much high doses. But again, you can only do that safely because every patient is so different. And the variability is so large, and that's one of maybe of the key messages. Due to the variability of the impact of the drugs, the variability of the patients, you should measure everything. And that's also for the neuromuscular block. Measure the neuromuscular block. You will see that sometimes you'll need a very low dose of neuromuscular block, and sometimes a very, very high dose. And again, also, it's the same with the abdominal. If I measure the abdominal compliance when we start, and if we see that the abdominal compliance is very large, okay, then we didn't need to ask the patient to reduce body weight, because then you will even able to work at the low pressure. But we don't have good predictive models yet, or we cannot measure the abdominal compliance before. Once we can do that, I would agree that we measure the abdominal compliance, and we said the ones with a small abdominal compliance, that's the one who really has to lose body weight.
Thank you, Jan. All right, our second speaker is Dr. Rainer Lenhardt. He's a very good friend of mine. I've known him for almost 2 decades. He's a professor of anesthesiology at University of Louisville in Kentucky, USA. He's also one of the board of directors of our society, Ispcop. He is going to present a talk on the morbidly obese patient undergoing robotic abdominal surgery and its implications perioperatively.
Thank you, Dr. Wadwa. Good afternoon, everybody. My pleasure to be here. As Dr. Wadwa mentioned, I'm going to talk about the morbidly obese patient undergoing robotic abdominal surgery. You're going to have a lot of redundancy from the first talk from Dr. Mullier here, but it may be actually a good thing to have some redundancy. What I want to do is talk a little bit about indications and advantages of robotic surgery in general, and that of course includes the bariatric patients, that includes the obese patients. And we'll talk a little bit about, and please see this as a review, a short review about pulmonary function of morbidly obese patients and robotic abdominal surgery. And then I want to summarize what can we do to improve our physiologic situation in the morbidly obese patient who undergoes robotic surgery, talk a little bit about ventilation management, and at the very end about paralysis management. So indications for robotic abdominal surgery are manifold. Of course, we've heard a nice talk about bariatric surgery. That's one of the most important, if not the most important, a part of robotic surgery in the obese patient. Think about when you look at the program for this convention, you see that there are huge lectures on robotic bariatric surgery all over the place. Now, I will talk about robotic surgery that's non-bariatric in the obese patient. Now, what else are indications? The main indication worldwide for robotic surgery, by far, is prostatectomy. We have patients who undergo nephrectomies, cystectomies, then, of course, a huge array of colorectal surgery, and last but not least, gynecological surgery, and that's what I'm going to focus on here in the next 10 minutes or so. Now, why do we actually do robotic surgery to begin with in the non-obese as well as in the obese patient population? Well, because robotic surgery, although it seems to be very expensive, has distinct advantages over open surgery and even over laparoscopic surgery. We clearly see, and this is all evidence-based, reduced blood loss. We see reduced post-operative pain, both in the recovery room as well as later on at home or on the floor. We have clearly shown to reduce the hospital stay, which is particularly important in societies like the United States, maybe not so important in like my home country, Austria, where we don't care that much about ambulatory surgery, but in the US we do. There is faster return to urinary and bowel function, and there clearly is a reduction in surgical complications. I'll show you that in a moment in hysterectomy patients. Here we go. This is a paper from 2019 looking into robotic hysterectomy versus total abdominal hysterectomy. RHE stands for robotic hysterectomy, and you see, although in this particular trial the duration of surgery is about 13 minutes longer as a mean, the length of stay is particularly shorter. We're talking about 1 day, so that is basically ambulatory or day surgery, versus if this is a total abdominal procedure, hysterectomy, total abdominal, the average in this case, in this study, was 3.2 days. Estimated blood loss is halved when we do robotic surgery, for reasons I don't want to go into because we don't have the time. But it's fascinating to see that the open abdominal procedure, no matter how good the surgeon is going to have significantly higher blood loss, at least in hysterectomy. And last but not least, at the very bottom, you see the 30-day SSI rates, surgical site infection rate, which is a big deal for our patients, which is a big deal for our surgeons. And as you can see, it's very low. It's 1.4% in the robotic hysterectomy population. And in my hospital, it's actually 0.2%. We looked at these data just before I came here. Versus in this study, the total abdominal procedure was associated with a surgical site infection rate of 8.5%. So many reasons to do robotic surgery. Now, when we look at our patient population, the morbidly obese patient population, we are talking about BMIs 40 and above. These patients have a significantly higher likelihood to acquire any kind of cancer. You see here, I just put a few of them: breast, prostate, colorectal, renal, endometrial. All of them, other than breast, can undergo robotic abdominal surgery. GYN-wise, we see endometrial cancers that are more likely to occur in the obese patient population. Again, my own population, we see 70% of our patients who suffer from endometrial cancer are obese or morbidly obese. Now, you see patients are more likely to suffer from a uterine fibroma, ovarian cysts, also C-section and others. So most of them can actually undergo robotic abdominal surgery. Now let me move on to pathophysiology. Again, just a short review. Keep in mind that we have the patient is morbidly obese with a lot of extra pressure on the thorax coming from the thorax itself and, of course, from the increased abdominal pressure. Compliance of the thorax, compliance of the lungs is significantly reduced. Airway pressures are increased. Resistance is increased. And, of course, there is a risk in barotrauma that is associated with longer robotic surgery times and with higher BMIs. Old study that you all know about from Jones showing that the higher the BMI, you see this on the left side of the slide, the higher the BMI, the lower functional residual capacity, which is a major problem intraoperatively. Now, on the right side, you see a reverse volume, an expiratory reverse volume that is also significantly reduced when the BMI goes up. So this is just pathophysiology of the morbidly obese patient. And now we're putting the patient under robotic abdominal surgery, which means the patient will, here you see our attending and our resident working on one of the patients doing a robotic hysterectomy. You have this pathophysiology of your morbidly obese patients, and now you put the patient in Trendelenburg position and you insufflate the abdomen so that the surgeon can actually work on the patient with the robot. So not only do we have pathophysiology of the obese patient, but it's aggravated by Trendelenburg and by pneumoperitoneum. Here's the robot in action that we all know. Now, what happens to respiratory mechanics if we have the morbidly obese patient who is in Trendelenburg and in pneumoperitoneum? Well, as I already mentioned, we have increased inspiratory pressures, peak pressures, plateau pressures. We have a significantly reduced functional residual capacity. We have a significantly reduced lung compliance. With modern ventilators in the operating room, we can measure both. We can measure dynamic compliance as well as static compliance. And we see that the compliance goes down by 50, 60, 70%, which of course makes everything harder for the anesthesiologist to breathe for the patient. Then of course end-tidal CO2 goes up as well due to reduced minute ventilation or due to increased absorption of carbon dioxide. In addition, keep in mind that with a Trendelenburg position of 30 to 35 degrees, most of the lung is below the left atrium in the west zone 3 and 4, and we get an even worse ventilation perfusion mismatch. We get more atelectasis, and we may, particularly in longer robotic surgery, we may have a more pulmonary interstitial edema. And that brings us to the potential complications that we see intraoperatively as well as postoperatively. And there are mainly the pulmonary changes, hypocarbia and hypoxia. We can also see pneumothorax, pneumomediastinum. These are rare problems, but these problems can occur, and then we have to treat these patients immediately. And then there is an array of other potential complications that robotic surgery yields, particularly in the morbidly obese patient. These complications are much harder to treat than in the non-obese patients. But let me focus on the pulmonary function and the pulmonary problems, mainly hypocarbia and hypoxia. Here you see again, the patient is morbidly obese, in Trendelenburg position, the trocars are in, the abdomen is insufflated here with a pressure of 30 millimeters of mercury. Typically, our pressures are still very high. We're no way close to 8 that Dr. Muller was saying about. We are in the 13 to 15 millimeters of mercury range. Now, what can we do about hypocarbia? And what can we do about hypoxia in our morbidly obese patient population? Well, we should start out with, as Dr. Muller pointed out, with protective ventilation. The protective ventilation is defined as a tidal volume of 6 to 8 mLs per kg, ideal body weight, or if you want to say predicted body weight, but not the actual body weight. Now that may work, it may not work. If the patient is becoming too hypocarbic or too hypoxic, then we will not be successful with a tidal volume of 6 to 8 mLs per kg, and we may have to increase minute ventilation. Now, there should definitely be a PEEP on every patient. That can be individualized. I put it here as 6 to 8, but it can be 10 or 12 in certain patients who particularly tolerate a higher PEEP hemodynamically. Recruitment maneuvers should be done. Now, don't kill me under 30 minutes. Some patients need 50 minutes. Some patients need 1 hourly recruitment maneuvers, and some patients don't need any recruitment maneuver at all, even though their BMI is 50 or 55. Another way to improve hypoxia and hypercarbia is to change the IE ratio, and then can go all the way from 1 to 2 to 1 to 1, inspiratory to expiratory time, or even 2 to 1, which would be a true inverse ratio ventilation. If you have a very modern ventilator, you might even do APRV, airway pressure release ventilation, in patients that are particularly prone to become hypoxic during surgery. And last but not least, again, having modern ventilators, we can try a hybrid ventilation mode, which means we combine pressure control ventilation with volume control ventilation, and that's then called PCVC, or pressure controlled volume guaranteed, or pressure regulated volume control, depending on which ventilator you are working with. Now, last but not least, and again, very, very important, Dr. Mullier pointed that out, is that the morbidly obese patient population, of course, has a reduced abdominal compliance and needs more pressure in order to have the surgeons be successful with robotic surgery, or abdominal surgery in particular. So what needs to be done if we want to help our patient to have better tidal volumes, to have less hypercarbia, to have better normoxia, less hypoxia on the one hand, but also assist our surgeons to have better operating room conditions? We've got to do a monitor. We have to have a monitoring system in place. In this case, it's an accelerometer. You could also use an electromyometer if you want to. Whatever you have available, that should be used not just at the end of surgery to reverse the patient, but it should be used throughout the robotic abdominal procedure. Now, what can be done when you measure the level of paralysis? There are different levels. We have a level that we call a moderate level, where we have a train of 4 that's positive. We have a level that we call a deep level, where we have a train of 4 that's negative, but has a positive PTC, which stands for positanic count, that should be in the 5 or so range to say, okay, this is a good, deep block. Now, having said this, we set out to do exactly that. We randomized our patients, obese and non-obese patients, to either a deep block, suggesting that PTC is positive, train of 4 is negative, or to a moderate block, and then let the surgeon tell us every 15 minutes on this so-called Leiden surgical rating scale what the... Okay, sorry, I'm not in the picture, I see. Sorry. What the quality, the surgical quality in a specific patient, obese or non-obese, would be. So we stratified these patients to obese and non-obese on the one hand, and on the other hand to deep paralysis and to moderate paralysis. And we used this surgical scale, as you can see here, that goes from 1 point, extremely poor conditions, acceptable, good conditions, optimal conditions, and we asked the surgeon every 15 minutes, we asked the surgical assistant every 15 minutes, and they gave us their subjective score. And here are the results that I am presenting here for the first time. Now, the surgical rating scale on the left side, and on the right side you see one group that has a BMI on average of 25.8. That was the group with a BMI of less than 30. And the second group was the group with a BMI of more than 30 that had actually a mean BMI of 43. And as you can see, taking the data together, both the moderate paralysis as well as the deep paralysis, you see that there is a pretty good, actually a very good compliance and surgical field quality in the non-obese patient population with a mean value of 4.5. Pooled data in the obese patient population was 1 score less, 3.5, so significantly less compared to the non-obese patient. Then patients, again, pooled in terms of pooling the surgical assistant and the data from the surgical assistant and the surgeon, would show a very good compliance in the non-obese patient population. Sorry, a good score, a very good score in the non-obese patient population, regardless of the level of paralysis. However, when you look at the very right side, you see that this patient population that had a BMI on average of 43 had a significantly lower paralysis, had a significantly lower quality, surgical site quality, when moderate paralysis was applied. The number here 3.4, and the number in the patient population, the big patient population that was actually under deep paralysis throughout the hysterectomy, they were all hysterectomies, had a significantly better oxygenation and a significantly better quality, surgical quality, surgical site quality. And that brings me to the last slide. We have a standard operating procedure for our robotic patient population that holds true for obese as well as non-obese. I just want to point out that neuromuscular monitoring in our robotic patient population is a must. It's got to be done with every single patient, regardless of if the patient is obese or non-obese. And the biggest problem that I try to point out here in these 15 minutes is the pulmonary function in these patients. They can easily get hypoxic and hypercapnic, and there are ways to improve hypoxia and hypercapnia that you see on the right side. Every patient is an individual, every patient is very different. You need to try out what might be best for the patient. That includes the PEEP, that includes recruitment maneuvers, that may include an inverse I to E ratio or APRV ventilation. And
Dr. Lenhart,
and I'm already done. Last not least, train of 4 ratio at the very end is important because our morbidly obese patient population must never have residual paralysis. So we need to measure and we need to reverse the right way. And with that, I thank you very much. Sorry for the long time.
We'll take only one question for Dr. Lenhart as we have to move on.
Yes, thank you. You stressed the role of the pulmonary function during this kind of surgery. I agree with you, and we performed this small study about the monitoring the lung function during a robotic prostatectomy with the electric impedance tomography, with the AT. We set the best PEP level on the AT, and we found that the group with the AT monitoring and the best PEP level had a low incidence of atelectasis in the postoperative period. So what do you think about? Is there a role for this monitoring during this kind of surgery?
Please repeat the role of which monitoring?
Electric impedance tomography, the pulmovista. Okay.
I have no experience with that. So unfortunately, I cannot give you an answer to that question.
Okay, thank you.
Sorry.
Maybe you can educate us about electric impedance tomography. Yeah. Would you like to educate us?
Yeah. When you want. You
Now?
welcome. Now, pulmovista is quite similar to a CT scan, to a lung CT scan, but without radiation. So this is a non-invasive bedside monitoring we use to do in ICU. I'm also an ICU physician, and I move in OR with this kind of machine. And at the beginning, we wanted to only to monitor the lung function, the recruitment, the alveolar recruitment with this machine. But with an update of this machine, we now may set the best level of PEEP during protective ventilation using this machine, because we saw on the display the duration of the lung as a CT scan. During the surgery, this is very important for us, because we had zero postoperative pulmonary complication after robotic surgery. After robotic surgery, yes. Prostatectomy, I mean, okay?
Thank you very much. That was very enlightening. And just one quick question. Would there be a difference between upper abdominal and lower abdominal procedures with this?
Yeah, of course, because we use this is a non-invasive monitoring. When the surgery is close to diaphragm, there should be an artifact in the reading. So you have to be very expert, and you should have a lot of experience in these methods. In the lower surgery, there is no problem. We have no problem to monitoring this function.
Perfect. Thank you very much. Thank you for that. Our next speaker is Dr. Farooq Badiuddin. He's a consultant surgeon who also does bariatric procedures in Sheffield, UK. He is also one of our collaborators, and he heads the IFSO committee on perioperative ERAMS survey that we have been doing over the last one and a half years on how much ERAS is being utilized by surgeons and anesthesiologists. So I look forward to your talk.
Thank you. Hello? Yes. Thank you to Adrian and Anu to inviting me for this particular session, and to IFSO in general for giving me this opportunity. First question, how many surgeons do we have in this audience? Wonderful. I'm happy to see the interest and feel the bondage with the surgeons here. It's important because as we proceed, we have been, as you just heard, we have been conducting this survey, and the response was rather poor. So just to see how much interest there is among the surgeons, it's good. Thank you very much. I was asked to give this talk by Adrian because it seems like there is a move by the surgeons to take up what's been traditionally practiced by anesthesiologists. I don't have any potential conflict of interest. Just a quick preview. Management of pain is a challenge both in the community as well as in the hospital settings. Sometimes we go too far, as we can see from the opioid epidemic that seems to be taking up not only America but many other countries. But then some of us seem to be going down the right path, which is down the path of ERAS and multimodal opioid-free or opioid-sparing analgesia. Control of intra and post-operative pain is a major component of the ERAS pathways, with multimodal analgesia being the key component of the protocol. So multimodal analgesia is defined as the use of more than one pharmaceutical class of analgesic medications, targeting different receptors along the pain pathway, where the goal of improving analgesia while reducing individual class-related side effects. Multimodal analgesia uses the synergistic effects of several agents. A, to dampen inflammatory response, which sensitizes the pain receptors peripherally, and to block the pain perception at the central level. Elements of multimodal analgesia include opioids in smaller doses or eliminating them altogether, non-opioid systemic analgesics like acetaminophen, NSAIDs, centrally acting drugs like gabapentinoids and ketamine, and then the local anesthetics administered by either infiltration, regional blocks, or the intravenous route. We focus on the regional block. Some of these agents may not be applicable universally due to patients' intolerance or contraindications and adverse effects on the renal, gastrointestinal, neurological, and cardiovascular systems. We have been using local blocks for quite a few decades, but the more recent availability of long-acting local anesthetics like bupivacaine, levobupivacaine, and liposomal bupivacaine have given us new perspectives in managing pain. Effective control of pain in the longer post-operative phase to cover the acute phase reaction and the inflammatory response when the pain tends to be at its worst in the first 24 hours. Let's move to abdominal blocks, which are particularly helpful in enabling early ambulation, effective breathing with minimizing pulmonary complications, countering the nausea and vomiting and drowsiness that comes with increasing doses of opioids. Several blocks are in practice for the post-op management of pain in abdominal surgery. There are 5 well-known: rectus abdominis block, transverse abdominis plane block, erector spinae plane block, quadratus lumborum block, and the inguinal blocks. For abdominal surgeries with anterior access by the general and bariatric surgeons, the most suitable blocks seem to be the rectus abdominis block and the transverse abdominis plane block. We believe that the transverse abdominis plane block tends to get better results than the rectus abdominis block, particularly with laparoscopic surgery where there is quite a degree of peritoneal stimulation. And I think there are few literature in the realm of anything to do with postoperative plane blocks in bariatric surgery. This is one of those reviews which seems to be a fairly comprehensive review of 21 RTCs and 6 non-randomized studies which were included. The results showed that the TAP block group required fewer opioid rescues. No difference was observed for nausea and vomiting or hospital length of stay, which seems to be the general trend in these studies. Meta-analyzed outcomes from our observational studies supported these results, suggesting decreased post-operative pain and opioid consumptions. Why surgeons? I mean, traditionally, my colleagues at the head of the table have been administering the TAP blocks through ultrasound-guided methodologies, and it seems to work pretty well. Well, the surgical laparoscopic route for delivering a TAP block offers certain advantages, one of them being direct vision of the abdominal wall from inside, thus minimizing the failure rate, which is known to happen with intraperitoneal injections or injections being given in the wrong plane. We don't need the additional equipment or the operator for the equipment, and in situations where people may not be experienced in delivering these blocks, the surgeon can actually do it themselves. And of course, it may reduce additional anesthetic time, which may be a debatable advantage, and potentially the cost of an additional billable procedure in economies like the USA. So this is a comparison between the ultrasound TAP and the laparoscopic TAP. So this was looks like a very nicely designed, prospective, randomized, patient and observer blinded parallel arm non-inferiority trial trying to prove that the surgical approach is no lesser than the ultrasound guided report. So they recruited 60 patients, almost half in each arm. And the results, of course, showed that there was no significant difference in postoperative narcotic consumption between the ultrasound delivered or the laparoscopic delivered TAP at the time of PACU discharge. And there was no particular change in the other parameters of ERAS. In conclusion, surgeon-delivered laparoscopic TAPs are safe, effective, and non-inferior to anesthesia-administered UTAPs in the immediate postoperative period. So it doesn't make us any less better. So I think a focus on the TAP itself, because I think that seems to be the one where we want a little bit of anatomy here, because there is a difference between delivering a TAP to a non-bariatric patient to a bariatric patient, and that's why I thought I'll just take it up for a bit on the anatomy. As we all understand, the anterior cutaneous and the lateral cutaneous nerves run in the plane between the internal oblique and the transversus muscle. And the focus generally is on T10, 12, and 10, 11, and 12. And those are the areas that you can see here where, oh, I can't use the pointer, where the area of anesthesia that actually occurs as a result of that. But if you notice carefully, most of these nerves actually are infra-umbilical at the level of umbilicus or below. Tends to work very well in colorectal surgery, but in bariatric surgery, we believe we need to actually tackle the L7, 8, and 9 as well. And that will probably require a slight modification in the technique. And this is just to show the plane that we would be going in. But this is what I'm saying. Look, we actually have the 10, 11, 12 with the traditional TAP that we do with the ultrasound guidance in the space, the petit strangle. But with bariatric surgery, this is an upper abdominal surgery. I believe with this, we would not generally recruit what you call the T7, 8, and 9. And this is where an additional injection at the subcostal area would be needed to block this area. I mean, I do, apart from bariatric, I also do fundoplications and upper GI hiatal hernia surgeries, as well as ventral hernias. And to get a total blockage of the abdominal wall, we do need to address these muscles as well, which are above the umbilicus and in the subcostal area. So I would think that we probably need a second higher infiltration in the subcostal anteriorly. And this is what I've been doing more recently with our upper GI surgeries. This is a video of what it looks like when you deliver a TAP. So you actually find the point, make sure it is over there. And this video actually combines the TAP with the rectus abdominis block. So once you find that the needle is over, there is a blunt needle, so it doesn't poke through the peritoneum. And then you find the plane, come back about half a centimeter to get out from the subperitoneal space to the transverse abdominis plane. And this here is where we are injecting that into between the muzzle and the posterior rectus sheath. So I mean, when you look at it, it doesn't seem to actually take a long time for somebody with modest amount of training. You would find that this is fairly easily administered, and we can actually use the visual, this thing from inside to make sure that it is in the accurate plane, and thus reducing the failure rate of these analgesias. So, of course, we can extend this a little bit further by adding adjuncts like the continuous infusion catheters, which can be left in infiltrating bupivacaine for anywhere between 24 to 48 hours. And also there are newer devices which claim to be able to do this through the port sites. Haven't had much familiarity with these. I was just aware that this is out there in the market, and I thought I'll bring your attention to this device which might be coming up in the future. In conclusion, surgeon-administered laparoscopic tap and rectus sheath blocks are a relatively easy procedure that can be performed after a short learning curve. Compared to the ultrasound-guided tap, there may be logistic advantages and potentially a reduction in the failure rates. The results of laparoscopic tap are not inferior to the ones that have been achieved by ultrasound-guided tap in terms of reduction in the opioid requirements. So, point is, we may require a 4-quadrant block for upper abdominal bariatric surgery, while the original may have hold good for lower abdominal surgery. I conclude. Thank you.
Thank you, Dr. Badiuddin. We'll take questions from the audience.
I guess I'll go again. This is an interest of mine. What are you using in your tab blocks? What is the cocktail?
Oh, bupivacaine 0.25% administered 20 ml. Well, we're actually now using 15 ml on the 4 locations with the bariatric patients. So it's 15 on the top, subcostal, 15 in the petit triangle, and the same on the other side. So it's altogether 60 ml or 0.25 bupivacaine.
May I ask a follow-up question to the anesthesiologist in the room? Is there any utility? We've started experimenting with different cocktails, if you will, of 0.25% Marcaine with epinephrine. We use 90 mLs because I'm not good at math, and that means I can use 1 cc per kilo, and it makes things easy. We had 4 milligrams of Decadron as well as 1 mic per kilo of Presidex. Is there anything that anyone else would put in there to try and optimize the length of neuromuscular blockade?
I think that's the best combination that we know. Dexamethasone 4 to 8 milligrams is probably the only adjuvant known to increase the duration. We have personally no experience with dexmedetomidine unless somebody else in the room has experience. But really, dexamethasone is the only adjuvant that is known to prolong the duration, per se.
Well, thanks for a very nice lecture, and indeed, it's important if a surgeon can do that, it's really helpful. A short question before coming on that. Do you do it before starting the surgery, or at least you have insufflated, or at the end of the procedure?
At the end of the procedure.
Yeah.
I think we do get it, because we do not know. These procedures could take quite some time depending upon what surgery we are doing. So when before the patient is woken up, probably just after closing, actually now we're doing it before we close the ports. And then we close the ports, which is an additional maybe 5 to 10 minutes.
Well, it will work at least quite long, unless we can go for the additives. But otherwise, it is really recommended more and more to start at the beginning of the surgery, to also reduce the requirement of the drugs or the opioids intraoperative. But it's a little bit aspect. Now, for the additives, and Anu is real right, the dexamethasone is the one most proven, although there are a lot of other additives you can add. But most studies today are showing also that even if you add them intravenously, you get the same results compared to adding them locally with the drug. And that brings also something quite interesting, that you can probably go on for only dexamethasone added, but dexmedetomidine is enormously elongating your local regional block also. So if you would combine that intravenously, like with opioid sparing technique, be aware, and it's even helpful to have a block that is also working a lot longer.
Sure.
Yeah. There's one remark on the, if I can, on the liposomal. If you use liposomal bupivacaine, it's great. You can have it very long. Never combine that with intravenous lidocaine. infusions as we're doing. It could be very dangerous because the lidocaine given intravenous will get in solution in the liposome and push the bupivacaine out. And so you might get, lidocaine is never toxic. You can even give 10 milligrams per kilogram without any problem, but bupivacaine is quite toxic. And so the lidocaine diffusing in the liposome, pushing the bupivacaine out of the liposomal bupivacaine can create a toxic dose.
Yeah. Jan, what do you think? I just want to know, what's your opinion on the infusers which continue to infuse in the... we've been using them more recently for up to 24 hours. Would that be something... I mean, of course, it's a little bottle that the patient carries around.
It's a little bit complicated, and I think for routine use, it will never really break through. And for the patient mobilizing, and they will think you have to stay in bed and so on. So the liposomal bupivacaine is great for that.
Yeah. Some people have been using that in the literature, you could see, but personally, no, we haven't done that.
It was pushed by drug companies like that produced those elastomeric pumps.
Yeah.
But then we realized that the elastomeric pumps actually had a lot of error rate, and so it has really fallen out of vogue. And nowadays, like, patients are up and about in a few hours after surgery, and when you combine all the multimodal analgesia that you give orally to the patients preoperatively, combined with all the intraoperative multimodal analgesia, like I have I will always give IV Tylenol at the very end of the case, like right before extubation, because the peak effect is in 15 minutes. So when you combine IV medications that you give at the very end of the surgery will prolong the analgesia. So all that combination has taken the local infusions out of vogue actually for us, and the error rate is so high with those pumps.
Yeah, just one comment. I mean, my experience with this method actually started off not in bariatric surgery, but in laparoscopic ventral hernia repairs. This is one procedure which paradoxically, even though laparoscopic, is probably far more painful than an open procedure.
Very painful, yeah.
It's because of all the tacks we use which go into the muscle, the whole of the abdominal wall becomes like a board. And in those circumstances, the blocks work amazingly, and they tend to actually ambulate very quickly. But once you get past the 24-hour point of ambulation, there doesn't seem to be a tendency to go back afterwards. That's
At the end of last year, the FDA has approved a paste that consists of meloxicam and bupivacaine. And the data have shown that this is a paste when you put it on the wound, as opposed to liposomal bupivacaine that you have to inject, that the pain control exceeds 2 days. So it's going up to 3 days. My question is, do you have any experience with this kind of a paste? And unfortunately, I cannot tell you the name of it. I forgot.
I don't have. I'm not sure if anybody else has any comment on that. Certainly not.
Is it the one that's produced by Heron Therapeutics?
Yes.
Yeah, I have heard about it. I have no experience with it.
Anybody in the audience has experience with this paste?
Can you go to the microphone, please, because nobody can hear you.
Adrian can come here.
But we'd have to look carefully at the data, because it just reminds me of the people back home in my old country, Malta, that used to put water from Lourdes on the wound. So just want to make sure it's not exactly the same thing, because they got some spectacular infections then. Anyway, that's all I have to say. What else do I add to the mixture? Perhaps look at the literature from the orthopedic LIA studies and see whether you'd like to add an anti-inflammatory as well, with due regard to whatever else is impacting on the patient's coagulation cascade.
Thank you, Adrian.
Okay. So, I'll just start my introduction from here. I'm giving the last talk after lunch, aren't I lucky? I am the guy that put together this meeting, and I welcome you all to Napoli, and I thank the organizers for accepting my contribution to this meeting. So,
thank you, Adrian. So, Dr. Sultana likes to give his own introduction. He is the current co-president of the International Society of Perioperative Care of Obese Patients. And it is true that he put together this great panel with all the wonderful speakers. And he is an anesthesiologist in Sydney, Australia. He's in private practice. And I invite him to the podium for his next talk.
Okay, just quickly, how do I move the slides, please? Ah, yeah, got it. The screen doesn't seem to be moving with the screen I have in front of me. Sorry?
The microphone, please.
The microphone, yeah.
Okay.
Okay, good, excellent. All right, so I need no further introduction. I don't have any disclosures. And I'm going to take you today on a little bit of a personal tour of the literature that has caught my eye roughly over the last 10 years. We will stray slightly outside that parameter, and I will also give you one or two of my private pearls of wisdom. What's been happening? What's new? What's the best? We'll go over preoperative assessment, pre-oxygenation, airway methodology, anesthesia technique, and perioperative nausea and vomiting. I have intentionally skipped acute pain management. In Toronto, there's a lady who's about this tall. Her name is Frances Chung, and she is Miss Sleep Apnea. Back in the day, 2016, she perfected a questionnaire that we administer to all patients, now called the Stop Bank questionnaire. This is just an initial intro into whether your high BMI patient has or has not sleep apnea. It doesn't stop you from performing sleep studies or from performing 4 weeks of preoperative CPAP to optimize their care intraoperatively. Moving on to the most recent paper that caught my eye from the Journal of the American College of Cardiology by a lady with an Italian-sounding surname from the Mayo Clinic. The next topic, moving away from the lungs, the heart. The heart and the patient with a high BMI is a cacophony of problems, and you have to address them together. It's like they're sitting on a seesaw, metaphorically speaking. You have to fix the heart to fix the fat, and you have to fix the fat before you fix the heart, and they follow each other quite nicely. My good friend and colleague from Padova, Michele Carron, had the courage as an anesthesiologist to put a review article in the British Journal of Surgery, and he went over all these body systems head to toe. And as you can see, the high BMI patient has problems beginning from their central nervous system to their heart, to their intra-abdominal organs. Again, the problem of respiratory control and sleep apnea. In addition, there seems to be a specific lung lesion that accompanies body weight, and also that lung lesion improves after weight loss. In any case, all these various systems have to be optimized before the patient reaches the operating table. One of my co-presenters today, Rainer, was invited, as were many of our Ispcop colleagues, to contribute to the review edition of the Saudi Journal, and he wrote on preoperative assessment. And there is his summary. He's addressed some of those issues in his robotic talk. But again, I cannot fail to emphasize that the detailed preoperative assessment and pre-medication of the patient's systems rather than of the patient's brain has to precede the patient's journey to the operating theater. In terms of preoperative assessment, it has to be multidisciplinary. We will often have to involve colleagues from other specialties. It has to be comprehensive, as we said, head to toe. We have to identify and correct the comorbidities, and we have to tie this in with our plan for the post-operative care. Indeed, there are in this room and in this meeting many enthusiasts for day surgery bariatric care. And we have to optimize the preoperative assessment to tie in with whatever we're planning to do with the patient, whether we send them home or whether we send them to the smart doctors in ICU. What about pre-oxygenation? This has moved quite dynamically in the last few years. We now recommend a high flow. Even if you're using a simple anesthetic machine, you should dial up to 15 liters. And we now have the option of using high-flow nasal oxygen. In a study from the UK, London in particularly, it came out just marginally ahead of high-flow pre-oxygenation with a standard anesthetic circuit. However, in my own practice, I use it all the time. I use it almost exclusively. I do believe that it is superior, and not only that, an aspect which is not mentioned in the literature, it makes you hands-free. It's like you're moving in a different universe because the machine is pre-oxygenating the patient while you're thinking, performing, and acting on the induction and the intubation. Now, there is a little bit of controversy in the literature. Is a high BMI necessarily associated with difficulty of airway management? Well, here is a story that not only made the anesthetic literature, it made the Guinness Book of Records. And I quite like to quote this, and I do have permission from the first author to reproduce his photographs. In Saudi Arabia, some time ago, there was a gentleman who was 611 kilos. He was retrieved by the emergency services, knocking down his wall at home, and airlifted to the hospital, where the authorities decided that he should have a sleeve gastrectomy. Now, this gentleman, at 611 kilos, according to the description in the case report, was intubated under deep CVO with a glide scope. So, clearly, there are some difficulties associated with high BMI and the airway, but if you have a well thought out plan, you can use whatever you like and whatever works in your own hands. Indeed, the British like to do the almost biannual audits called NAPS. National Audit Project number 4 was all about the airway. And interestingly, in NAP4, obesity featured very prominently. In fact, of 184 reports submitted to the panel, 77 were obese. Of 133 reports of difficulty under anesthesia, 53 were obese. Of the 16 deaths, 4 were obese. Of the 3 with brain damage, 1 was obese. And of those requiring emergency front of neck surgical access, 19 out of 25 were obese. And very importantly, of those requiring intensive care or a prolongation of the hospital stay as a result of their airway episode, 29 out of 33 were compounded by obesity. I'd now like to introduce another catchphrase: universal video laryngoscopy. Before I attended this meeting, I hadn't realized that in a surgical meeting you have to have both a video and a pie chart. I promise you there will be both a video and a pie chart in this talk. So at the peak of COVID, the group from Montpellier wrote a short paper in The Lancet showing how video laryngoscopy has much to offer over conventional laryngoscopy. And just looking at the time and motion of the young lady in the video here, you can see that even though she's not working in a COVID environment, doing the intubation by video is surely far more safe, far more elegant, and altogether better for everybody, including the operator, to be doing it from a distance, standing up, than putting your airway next to the patient's airway. This is a concept that is now supported by an important group, again from the UK, led by Tim Cook, where they suggest, and they present cogent data for it, that video laryngoscopy should be ubiquitous both in the operating theater and in the intensive care unit, and particularly so, I might add, for the patient with a high BMI. Is there a role for supraglottic airways when we manage the morbidly obese patient? Now, if you look at the difficult airway algorithms from the UK, US, and Italy, they all end in one common pathway, that is supraglottic airway for rescue. So surely, if we are going to use a supraglottic airway for rescue, we should also be familiar with the supraglottic airway during routine use in the high BMI patient. And interestingly, this Cochrane study back in 2013 came out in support of that. The supraglottic group, at this stage, they were still only using the ProSeal, which was the prototype second generation supraglottic airway. had less respiratory episodes in recovery, better oxygenation, and overall a better outcome. Admittedly, that's only one Cochrane review, but I think it is reflected in some of our practice with the high BMI patient, and that you have to think very carefully whom you manage with a supraglottic airway and whom you manage with intubation, and weigh up in your own hands what's better for the patient. Emphasizing that if you're planning to use a technique for rescue, you should be damn well sure that you can use it under routine circumstances as well. Of course, there's not one supraglottic airway, there are many, and at the expense of some introspection, this is from our paper with Anu and Lauren Berko from Florida about alternative methods of managing the airway. We really have to move past the classic supraglottic airway and only use in the obese population a second generation or better supraglottic airway. In other words, we must always have the backstop of gastric drainage as a safety feature. Now, this is an important paper because it's about opioid-free anesthesia and it's not by Mulier. Therefore, we have to lend it some credence. This group analyzed their opioid-free technique, which is closely mirrored on the technique that we heard from Jan, and they showed superior performance in recovery room aspects, including quality of recovery, quality of pain management, and elimination of perioperative nausea and vomiting. The concept that total intravenous anesthesia and opioid-free anesthesia was able to completely get rid of the problem of perioperative nausea and vomiting, even in the absence or even in comparison with triple prophylaxis, that is dexamethasone, serotonin inhibitor, and other drugs such as droperidol or cyclizine, was introduced by, again, one of our good friends from Florida, Patrick Zeman-Gimmel, who in this landmark study was able to show that total intravenous with opioid-free was superior to even triple prophylaxis accompanying a conventional technique. Here's the pie chart. What are we trying to achieve when we do opioid-free anesthesia? We want to achieve the cornerstones of our standard anesthetic techniques, including analgesia, hypnosis, neuromuscular blockade, amnesia, and hemodynamic stability, together with a new word coined by Jan called sympatholysis. It is quite remarkable how, using the opioid-free regime popularized by Professor Mulier, you can achieve hemodynamic stability well beyond that you can achieve with high-dose opioid. Now, in the anesthetic world, everybody loves a recipe. I have slightly fine-tuned what Jan has been preaching for the last quarter of a century to tell you what I do in routine practice in Sydney. So into the same 50 ml syringe, we pour 2 micrograms per ml of dexmedetomidine, 1 milligram per ml of ketamine, 10 milligrams per ml of lidocaine or lignocaine. And then we use that syringe as our opioid-free base, together with whatever propofol regime you wish to use. Obviously, in Europe, the UK, and Oceania, we have TCI. In America, they still don't have TCI. My preference would be to use TCI. And as a further development of that concept, we now have TCI available for dexmedetomidine. And I do use that routinely, bearing in mind that when you are using dexmedetomidine in combination with, say, propofol, your targets need to be much, much lower. In fact, I never move past the 0.1 nanogram per ml target, pretty much, when I use this technique. What about, we talked about adequate reversal of neuromuscular blockade. In some countries, Sugamadex is a dirty word because it costs so much. Soon it will go generic and it will become hopefully quite cheap. I am lucky that I practice in an environment where cost is not really a problem, and I would recommend an anesthetic technique with deep neuromuscular block based on the steroidal neuromuscular blocking agents and then appropriately antagonized by Sugammadex. And again, here the Bruges group have worked out how to use Sugammadex correctly using a formula for an augmented lean body mass equation. Just recently, Michael J. Scott's group from the USA submitted an evidence-based review to anesthesia and analgesia, focusing on quality and safety in bariatric surgery. And this touches on some aspects of ERAS, and it's important to note that they looked at preoperative intervention, intraoperative intervention, including a standardized anesthesia protocol, then how you manage your fluids. They talk about goal-directed fluid therapy, and then how to prophylax your PONV, and then how to achieve the best case acute pain management in the perioperative period. I would recommend this paper to you highly. In conclusion, the clinical care and anesthesia techniques of our patients have evolved over the last 10 years. I may be regarded by some as at the nadir of my career, but I'm still interested in what I do and I enjoy what I do. Largely because by applying these modern techniques, I can improve the care of my patients and confirm to myself that I'm at the cutting edge of my specialty. I have a little bibliography for you there, and I thank you for your attention, despite the late hour and despite the postprandial situation. I'll be happy to take questions as we go on from here. Thank you.
Thank you, Adrian. We would love to get questions from audience.
Okay, as a surgeon, I have a couple of things to comment or to ask. The first thing is that we in Italy, we have a very different type of population. We can have very tall people and not very tall people like me. And I found that in the practice, there is a huge difference if you have a 45 neck, if you are 1 meter and 70, or if you are 2 meters. So I found some very few papers on the use of neck height ratio. And so we are using a stop bang, not with the neck circumference, but with a neck height ratio, because I find it a little bit more useful in my practice. And I would like a comment on that. What do you think about that? And the second point is that as a surgeon, and I think that as far analgesia, post-op analgesia, we should be better, in my opinion. We are doing practically everything we are talking about today. We are using ERAS, we are using all the protocol. The only thing that we are not using is ketamine. That's the only thing that we are not doing. But everything what we said, what we listened to today, we are doing that. But in the first hours after sleeve gastrectomy, people very often are suffering a lot about pain. So it's totally different from gastric bypass, but in sleeve gastrectomy, we still have a lot of pain. So in my opinion, we should do something more. I don't know what, because you are an anesthesiologist, I'm a surgeon, but something should get better.
Okay, well, starting with your comment about neck height circumferences, basically any demographic that you can come up with that helps you to predict the sleep apnea risk and treat it accordingly, and or helps you to predict the airway management pathway, should be embraced. I don't think it is limited to Italy as to that people are different shapes and sizes. In fact, it is so important in the anesthetic literature that people are different shapes and sizes that I have a slide with two American people from popular culture, one guy being CeeLo Green and the other guy being Kobe Bryant. They may have the same weight, they're a totally different shape, they probably require totally different anesthetic management. And this concept has actually been now entrenched and scientifically proven in the concept of allometry, i.e. the anesthetic regimen is not worked out by BMI, height, weight, etc., but by the patient's shape. And the group in Leiden has come up with a series of mathematical equations that they have now integrated into commercial systems of TCI. That's where the dexmedetomidine TCI program comes from. So yes, people come in all different shapes and sizes, and the weight or the BMI is not necessarily a primary focus of what their management should be. In regard to pain management, I would highly recommend ketamine to you. Some parts of Europe have the mono enantiomer of ketamine, which is reputed to have less psychiatric side effects. But when you use ketamine in the way that has been described in the various acute pain literature, and particularly by Jan himself, i.e. in very small doses, sub-anesthetic doses or analgesic doses, you don't appear to have any post-operative mental disturbance, particularly if you use it in combination with dexmedetomidine. I think ketamine is a game changer in terms of the opioid requirement post-op, and I do agree that sleeve gastrectomies can be difficult to manage, both from the acute pain management point of view and the perioperative nausea and vomiting point of view. In my hands, I would insist on the surgeon doing pre-incisional, pre-laparoscopic tap blocks, guided through the laparoscope himself.
We are
the
doing
longest
that.
acting agent with the biggest mixture that you can get your hands on. I would use an opioid-free technique intraoperatively. If in the immediate perioperative period they require a bit of topping up with an opioid, I use a short-acting opioid or a medium-acting opioid such as fentanyl, and stay away from morphine and oxycodone. That is my own personal practice.
Thank you very much.
Are you giving preoperative oral medications?
We did for a long time, but actually we found inside the stomach that we were taking out the
Medications.
pills, so
Yeah.
actually we decided to stop it.
Yeah, only if it's given like 2 hours before they do melt.
Okay, maybe, probably, yes.
yeah.
We're
Again,
giving that 1 hour before.
I think in America that's largely driven by cost, in that a tablet of paracetamol or a Tylenol costs a few cents, whereas a bottle of intravenous paracetamol costs, what, $5 US? So, and again, those HMOs are looking at you very closely, so therefore you have to choose the most cost-effective way.
And I second Adrian's comment about ketamine. I mean, we use ketamine for everyone, and it may be the biggest change in practice that you may have to bring. But
Thank you.
ketamine and nitrous oxide both are amazing NMD antagonists.
Although I wouldn't mention nitrous oxide anywhere where we're talking about the bariatric population. It's gone, finished.
Go
It's
ahead.
not there anymore. It's not even in the pipelines anymore.
Even in my hospital, we use ketamine for this kind of patient. We
Yeah.
have a good feedback because I think ketamine acts on the psychological modulation of the pain. Pain is not only matter of drugs.
Of course,
but
of course.
It's a multimodal
Of course.
situation.
Yeah, yeah. It changes the memory of pain.
Quick comment to nitrous oxide. Nitrous oxide is a wonderful drug, and we now know how it works. However, it's the worst of all volatile anesthetics from an environmental perspective. So we have started to omit nitrous oxide completely, regardless if this is an obese or non-obese patient.
Yeah, not only are hospitals being built without nitrous pipelines, hospitals are actively removing the nitrous pipelines.
That is my biggest worry, but we will move on from that. Farouk and Yan are waiting in line.
Just a couple of comments on what you said about the pain in sleeve gastrectomy, as well as reduction of post-operative nausea and vomiting, which is the second biggest issue we face after pain in bariatric surgery. I have actually used scopolamine or buscopan as a adjunct to other pain modalities, because I think the sleeve pain really comes from gastric spasm, and trying to get that off actually might be one of the ways of helping that management of the visceral pain. And tablets are supposed to be working for visceral pain just as much as they do for cutaneous pain. That's what the literature says, we don't know. And about nausea and vomiting, we routinely wash the stomach with saline, about 500 ml of saline or water after the procedure is done. And the reason for doing that is to wash away any of the blood components that would invariably be there intraluminally, which can lead to nausea and vomiting as well as irritation. So washing the stomach actually, after some time, it helped us reduce the incidence of nausea and vomiting post-operatively. So routinely washing the stomach was one of the interventions.
Thank you. This is very interesting.
They wash the stomach before the exhibition.
At the end of the surgery.
Yeah.
Because it's a part of their...
It's a bit dangerous.
Well, just on going on that last question, and I agree on everything was just said, and I had the same argument as Farouk was just telling. The sleeves really have spastic activity, and the buscopan is one good order. What I always do is give them a patch of nitroglycerin that is also relaxing them. And metamizole, or the old Novalgin that I also reintroduced, is not a very good anti-inflammatory agent like the NSAIDs are, but a very good antispastic drug. So for the laparoscopic sleeve, a patch with nitroglycerin is for me always, and metamizole and needed buscopan, as Farooq was already telling, because a lot of these patients have spasm and not pain. And giving opioids or whatever is not helping at all.
No, not at all. I totally agree. I didn't understand the patch of
nitroglycerin.
Nitroglycerin
is working and prevented this spastic activity. But it all comes down to the details, and the ketamine or the S-ketamine, it's really wonderful. But again, you have to give that just before the painful stimuli will arrive from surgery. So if you give it too long before, it's not active anymore. So you keep, like, you can give a dose of even 12 milligrams, 25, 10 minutes before the incision is coming, also on the moment that is painful intraoperative. And then indeed there is no problems, hallucination, as long as your total dose is below the 50 milligrams intravenously. But it's the details that are so important, and the difference from patient to patient. The last thing is also keep your intra-abdominal pressure low. If it's low, there's no strain on the peritoneum, and the shoulder pain and everything is not there. But we have to take care of everything, and then the pain is not a problem anymore.
I hope I will do that. Thanks.
Thank you. Any more questions? Well, thank you very much for being here. And would you like to say something in Italian?
No. Thank you, everybody.
Thank you. Bye.
We should take a picture together before.